So welcome everybody, especially to Dr. Jimenez for being here for our December Health Policy Grand Rounds. This is the last in-person Health Policy Grand Rounds for the academic year. The spring Health Policy Grand Rounds will all be on Zoom because we have a lot of other in-person things happening in the spring. Plus there were some speakers who prefer to do it on Zoom because of their own obligations at their home campuses. So in the spring, starting in January, we are going to be on Zoom. In January, we have Daryl Gaskin from Johns Hopkins University talking. I've known him for years and am really glad we finally convinced him to do a grand rounds for us. He's great. So be prepared to be on Zoom for that, and we can have like a little watch party in one of the conference rooms in our suite, and I'll bring cookies. But today we have Dr. Natalia Jimenez, and she is as a physician and has an MPH and is at the University of Washington and also connected with Seattle Children's Hospital. She is the vice chair for equity, diversity, and inclusion in the Department of Anesthesiology and Pain Medicine at University of Washington, and also is affiliated with the School of Public Health there. So she's a pediatric anesthesiologist. So I see some anesthesiology people here, guilty as charged over there, who are here for the talk. And she has been doing NIH-funded work looking at barriers and facilitators to access to care among predominantly Hispanic and Latino children, issues around language access and culturally concordant programs. And rather than my going on what is a very distinguished biography, I will let us move directly to our talk.
Thank you. Thank you very much. And I'm very excited to be here and share some of the research that we have been doing at the University of Washington and Seattle Children's. I'm trying here. Okay. So I don't have any conflicts of interest, and this is my research funding. So for today, I have 5 objectives. The first one, I want to describe why traumatic brain injury among children in the United States is a public health priority, and some of our research that have called for attention, particularly for Latinx youth. I also want to identify risk and protective factors for disability after a TBI, with, again, a focus on Latinx populations. I will describe the co-development with Latinx caregivers and clinical providers of an intervention to decrease disability among Latinx youth with TBI. And I will share a little bit of baseline data of our current multi-center RCT testing this particular intervention. And as I hope that as I go through all of these things, I will be able to describe some facilitating strategies that we have used, as well as some barriers that we have encountered doing this community engaged research work. You're going to see a little bit of pictures from Seattle. Hopefully someone would like to visit us, and I will be more than happy just to host you. I'm going to loosely use the CDC public health framework. So I will start by defining the problem, identify risk and protective factors. Then I'll tell you about our intervention. And hopefully after we finish the RCT, if it is effective as we expect, then hopefully we can implement in real life. A little bit of background. So unintentional injuries are the leading cause of death for children and youth in the United States. And this is true for every age category starting at 1 year of age. Only infants have higher mortality due to congenital malformations, but otherwise it is unintentional injuries. And TBIs are almost like a third of this. So for 2020, there were 2,774 pediatric TBI-related deaths. But this is just one piece of the puzzle. This is also important to talk about disability related to TBI, and disability related to TBI is one of the prime reasons for disability in youth. And for the year 2019, there were 16,000 hospitalizations due to TBI. As you can see, and I just realized that that table is really small, so I apologize. But this is from the CDC as well. And basically, I'm trying to highlight here the primary mechanisms of injury. But basically, the idea of this slide is to tell you that all of these mechanisms are preventable, right? And for 0 to 4 years of age are falls, and starting at 5 years of age are motor vehicle crashes. And then I also highlighted intentional injuries in two age categories, which is less than 4 years of age and starting at 15 years of age. However, we have been talking about diagnosed TBI that has been diagnosed, but is this the true prevalence of TBI? So this is a very interesting research done with the National Survey for Children's Health, in which they ask parents 3 questions. So the first question is, have your child ever had a concussion or a brain injury? And then for those families that say yes, which was 5.4%, then they ask, did you seek care for this particular condition? And they were around 88%. And of those that seek care, they asked, did they diagnose a concussion or TBI? And this was 87%. So the prevalence of a diagnosed TBI is 4.2%, which is a little bit lower than the reported or suspected TBI. What is important to talk about is that this lifetime prevalence varies by the sociodemographic characteristics of the child. So it's higher among children insured by private insurance, is 5.1% compared to 2.8% for children in public insurance and 2.1% with uninsured children. It's also higher in children living in families with high socioeconomic status. So if you look, it's 5.7% compared to just 3.9% in the lowest socioeconomic status. And it's also higher among non-Hispanic white children. All children from minority backgrounds have lower prevalence of diagnosed TBI. And this is something that it doesn't correlate with what we expect, because children with, especially among those with low SES, minoritized backgrounds, what we expect is they have higher risk factors, so we expect a higher prevalence of TBI. So what are some of the risk factors for TBI, not only for injury severity, but also for disability? So one big one is rurality. So we know that children that have a TBI from rural areas have increased head injuries, and also they are at risk for delays in acute care. And after they are seen in acute care, they are also at higher risk of not receiving the needed services because they don't have enough access to mental health or specialized care in rural areas. We also know that socioeconomic status is associated with higher mortality and higher disability. And also we know that lower ACS is associated with a higher proportion of ballistic injuries. That these ballistic injuries also have higher disability and are higher in African American, Hispanic, and Native American children. And in terms of of injury severity, but of disability, we also know that children in public health insurance have higher unrecognized needs and unmet rehabilitation needs when they are diagnosed. And this is very important because nationally, almost 34% of children that are hospitalized for TBI have public health insurance, but the distribution of those children racially and ethnically look very different. So what happens on Latinx youth? So in Latinx youth, in the same study that I was telling you, the prevalence of diagnosed TBI was just 2.5%, which is nearly half of what it is compared to non-Hispanic children. However, there are other studies that report that Hispanic parents report around a 6% suspected TBI prevalence, which is much higher than what we have here. And I think that makes sense because they have the compounding effect of risk factors for TBI. So Hispanic youth are more likely to live in rural counties. They are also more likely to live in families with lower socioeconomic status, and they're more likely to have uninsurance or underinsurance. So with all of this prior information, I'm really interested in studying TBI among Latino youth and bring a little bit of attention to this because there is this discordance between the prevalence that we have and the risk factors that they have. So this is a cohort study of children with traumatic brain injuries, all severities, cared at 2 children's hospitals in Seattle and in Philadelphia. And these patients went to the ED and were discharged or were hospitalized for the TBI, so all severities for sure. 74% of this cohort were non-Hispanic were Hispanic children, I'm sorry. And these children, this is just an observational study, were followed at 3, 12, 24, and 36 months on a battery of the scales looking at disability. And what we found is that Hispanic children have higher short and long-term disability compared to non-Hispanic white children. And here I'm showing you the PITS-QL as an overall measure, but what I'm showing here, it was replicated in all the scales of community participation, communication and self-care skills, as well as health-related, obviously health-related quality of life. So here, what you can see in the left, can you see those numbers? I'm sorry, I can't, but I have contact lenses. So in the left, you have the baseline mean score, so before injury, and then you have the change from baseline to 3, 12, 24, and 36 months. And then you have the PITS scale for non-Hispanic white kids, for Hispanic kids. And I also added here, it was a very small sample, but I just want to exemplify something here of non-Hispanic black children from that cohort. So what you can see is like all groups had a decrease in health-related quality of life after the traumatic brain injury. And this is adjusted by injury severity and other factors, but nonetheless, that's what we see. But the difference between non-Hispanic whites and Hispanic children and non-Hispanic black is significant. A difference of 4 points is clinically significant in this particular scale. And then if you look at 12 months, the kids in the non-Hispanic black group, they decrease this gap with the non-Hispanic white kids, but for Latino kids, it is persistent. And there is very little, they continue to have this disparity up to 3 years after injury. And when you look at risk factors for disability among Hispanic children, it does make sense, right, to see this disparity. So they are more likely to have injuries at a younger age, less than 4 years of age. They're also more likely to be insured by public health insurance. If you see here, 78% of our sample was in public health insurance compared to only 17% of non-Hispanic white children. They're also more likely to have lower socioeconomic status, 68% versus 12%. And when we look at parental education, almost 60% of the parents had less than high school compared to only 2% of non-Hispanic white children. And even though limited English proficiency is not associated, it's not necessarily a risk factor to disability, it's definitely a risk factor to access care. And here in this sample, 70% of families spoke primarily Spanish. So after we saw this, we were really interested in knowing, okay, what is the response of these children to rehabilitation? If we get them to rehabilitation services, do they respond well? So this is another national data set of inpatient rehabilitation facilities in the United States and 10 years of data. And these are 10,000 children 6 months to 18 years of age who had a TBI. And when they get to a rehab facility, they have functional independence measures at baseline and then at discharge. And what we found is that they have similar functional gains and recover at the same pace than any non-Hispanic white children. So this is great news because if we get them to rehab, they will get better. There was a statistically significant difference in cognitive scores, but clinically it's really irrelevant. So then the issue here is that most of the patients that get hospitalized for a TBI do not go to inpatient rehabilitation. It's only a small proportion of these children. The majority of them go to outpatient, to a community to receive rehabilitation as outpatients. So because the majority of the Latino children are covered by Medicaid, I use the Medicaid market data set to look at hospitalized children with traumatic brain injury, and these were 9,000 kids. And what was important is, first of all, only 29% of children received any rehabilitation service after they were discharged from the hospital. And this is not only true for Latino children, any child in Medicaid, only 30%, even though 62% of them had moderate to severe TBI. And when we look exclusively at Hispanic children, they had even lower rates of receipt of speech therapy. And speech therapy for these kids is not only about speaking, it's basically about cognitive processes, and they're very important for them. So here, basically messages disparities develop after discharge from acute care and are higher among children that do not receive inpatient rehabilitation. So then we were interested in knowing, okay, if we discharge these kids to a community, why they are not getting to inpatient rehabilitation. So this is actually a beautiful study from one of my co-investigators, it's Dr. Molly Fuentes. And what she did is that she called, posing as a mother, seeking for services of a child with a TBI. And the only thing that changed was if the child was on public or private insurance. And we use a data set of rehabilitation providers for the state of Washington. So the first thing that it was found is that therapy clinics, not surprisingly, are more likely to accept private insurance compared to public insurance. For PT clinics, they're 30% more likely, occupational therapy 40%, and speech therapy 42%. So then we look at the difference weight to get for those kids in Medicaid to get an appointment. So if you look at PT, if you're in private insurance, it's 3 business days, and if you're in Medicaid, it's 7 business days. But if you look at speech therapy, that is so important, it's 20 business days for Medicaid versus 5 business days for private insurance. There were no difference for OT or rehabilitation medicine. So this is a huge disparity, especially because the majority of the rehab, the function and gains happen within the first 3 months after injury. Then what we did, this one, oh, sorry. So what we did, I was interested in looking at the intersection of Medicaid and language services. So we use the same data set, but we only call to ask, do you receive Medicaid and do you provide interpretation? Right? So for our state, only 46% of providers receive Medicaid, and less than 20% of providers receive Medicaid and provide interpretation. So really, for this particular population group, it's very limited access to rehabilitation. And then what we did is we look at the proportion of individuals more than 5 years of age that speak a language other than English at home. And these obviously, this is a little bit of an issue with this study. This includes LEP and bilingual families, right? So not all of them are necessarily LEP. Nonetheless, if you look at Washington State, depending on the county, the proportion is 3% to up to 50% in some of our rural counties. And when we look at the association or the relationship between the proportion of speaking another language and the availability of services, then for every 10% increase of the proportion of languages other than English, there is a 50% decrease in the number of multilingual services in that particular county. So this is really important because, again, this is barriers to access care. And for our state in particular, almost 50% of kids are under Medicaid insurance. And we have almost a 20% population that speaks a language different than English. So now we had a little bit of a better understanding of some of the barriers that these families were facing. But we, first of all, want to make sure that are we missing any barriers? And 2, are there any facilitators so we can design an intervention to help these families? So we did some qualitative work with parents of children that had a traumatic brain injury and were hospitalized at our county hospital, Harborview Medical Center. And these are parents of not only Hispanic, but non-Hispanic as well. And I also did focus group with clinical providers that take care of them. So here in Black, you're going to see basically barriers that were basically told us by all parents. And in orange, those are unique to Hispanic families. So in general, parents have a very poor understanding of the injury itself, the types of treatment, and the recovery expectations. There is a mismatch. Also, they talk about barriers during transitions of care, particularly in terms of communicating to providers in the community what they understood about the injury as they were in the acute center. And they also had very large gaps in knowledge about community resources and school resources. For Latino families, they also reported language communication barriers. Um, we also found that families talk about ineligibility for services, particularly associated to insurance, and that's not surprising given the prior studies we had. But for Latino families, they were also ineligible for services because of immigration status and language. And then among our Latino group, they talk about the lack of linguistically and culturally relevant education at the hospital, at the school, even at the web and media. So even if they want to learn more about TBI, they really don't have where to go. When we ask about facilitators, overall, the fact that somebody does coordination of care, especially if you think about a family that have a completely normal child before have a TBI with a very severe disability, is incredibly overwhelming. So scheduling of appointments, care coordination, and transportation are facilitators for sure. And the families that went to inpatient rehabilitation, they found that learning with the providers while they are in rehab, and the fact that social work is part of the team of inpatient rehabilitation, and they can link them to the community, specifically to school, it's big. For our Latino families, they talk about interpretation services, a facilitator, but more than that, navigation. So navigation, I know all of you know, but in case not, it's also not only about language, but it's about cultural care that is concordant with the patient. And specifically, a lot of our families come from Central America, Mexico, Guatemala, Honduras. Some of these families are indigenous families. For them, Spanish is a second language. So there is a lot of cultural brokerage done by our navigators. The fact that we give written instructions in Spanish is useful. That seems very intuitive, but we're pretty good in the hospitals giving verbal instructions through an interpreter and giving a piece of paper that is in English that is absolutely useless for the family. Some families ask for legal support, especially to access school services, and they also talk about cultural humility from clinical providers. So at this point, we're at the point that we are ready to kind of design the intervention with the families. We know that there are many factors that we cannot affect, but there are others that we can definitely do. And one is knowledge around TBI and treatments, and the other one is facilitating access to care. We also know from other disciplines that education and navigation programs are highly effective for Hispanic families. We have seen that in asthma management and diabetes management. So, and we also know from these programs that the most benefit is among those families with low levels of health literacy and lower caregiving self-efficacy. So based on that, we created the brain injury navigation and education programs. And it's very simple. This intervention has two components. One is education component. The education is particularly to provide knowledge or education about TBI and therapies. But the other piece of the education is to give education about resources in the community and the school so parents can advocate for their kids. And in green, you have the navigation component. And the navigation component has also something in particular, which is it provides navigation, but it provides navigation through the phone, through three-way calls. So the navigators are basically being models for the families so they know how to access things. And the idea is that this affects parental health literacy and self-efficacy, and this translates in behaviors, primarily adherence to treatment, and then this will affect child outcomes. So these are this is our booklet, and a couple of things. It's a very simple booklet, but a couple of things that I think is worth mentioning. So the first one is we have mirror translations or mirror versions in English and in Spanish. And I don't know if you had this experience that you go to the website and it says en español and you click and it's a horrible PDF with three things, right? And this disparity is unacceptable at this point. So this is exactly the same book in English and in Spanish, so people can follow them at the same time. It allows for customization. It's very simple, but it's effective. So I don't know if you can see there are little squares close to each one of this. You have from concussion to epidural hematoma, right? So when we talk to a family, we said, your child had a traumatic brain injury, had a subdural hematoma, check, right? This is your book. So they can refer to book and understand a little bit better the injury, and has a lot of visual aids. And we work really hard to make these concepts that are so hard into an easy concept for families with low levels of education. The other piece that we do, the booklet has 4 chapters or 4 pieces. So the first one is about TBI, the second one is about rehabilitation, third one is about community resources, and the fourth one is about school resources. And the families inform these topics. So we talk about advocacy. So probably you have this experience, especially with patients from Central America and Mexico, and myself included from South America. We're not used to shared decision models, right? We're used to this idea, that the doctor tells us what we have to do, etc. The shared decision models can be a little bit intimidating, especially if you don't know the system and you don't know the language. So at the end of each one of the chapters, we do these pieces of questions to ask your provider. So we try to prompt our caregivers to initiate communication with the provider, promote family-centered care and skills building. The navigator is not a new concept, especially for people doing research in cancer. But what we incorporated here in our navigation piece were 2 pieces. One, the piece of support. So we basically have this navigator kind of cheering for the parents as they go. And the second piece is the piece of school reintegrating to the school. So part of what the navigators have to do is to make sure that they connect families to the school system, particularly because kids can receive, through IEPs, they can receive some of the rehabilitation therapies. So we piloted this in Seattle. We had only 14 families, but all of them did the 3-month program. If you can see the median number of, let's say, things that the navigator had to do were 3 for this, but some families require like 18 or more. But they are all around like care coordination primarily, but with high levels of satisfaction from the family. When we look at it on our outcome, which is adherence to treatment, and here for the pilot, we only use the first set of appointments. So you're going to see our intervention group in dark, and our usual care group, it's a historical cohort. So in our group, 86% of appointments, 86% of patients completed all their first appointments compared to 51% in the historical cohort. Right? And for those that did not complete all, some 10% did some appointments and only 7% did not attend any appointment compared to 32% from the historical cohort. When we look at self-efficacy, there are 2 scales. This is the self-efficacy to care for a child with a TBI. At 3, which is the blue line, is the adequate self-efficacy. So after 3 months in the intervention, parents felt really comfortable taking care of their child. Obviously, the confidence intervals, which are 14 people, but in general, you can see the trend. And then we do also what we call community self-efficacy, which is their self-efficacy to get services in the community. So that's a little bit harder because it requires language. It requires that the health system is open to that type of patient. But still, I think the trend is to gaining some more self-efficacy. And here is our PQL. And what I want to show is 2 things. The first thing is the baseline, right? It's above 80, which is a normal PQL. And it really goes below 50, which what denotes is that the severity of injuries of these kids are really, really high. Then the other thing is that there is a trend for recovery, and that trend continues after the 3-month period. So this is a little bit different from what we saw in our prior study, in which there was no gains, right, after a 3-month period. So I think this was encouraging for us to proceed to our RCT. Before I go to RCT, I want to talk about the school for a minute. So this is from the report of Congress on traumatic brain injury. And only 50% of pediatric TBI patients receive hospital to school transition services. And this is really problematic because this results in lower cognitive and behavioral function and difficulties with the school adjustment. And particularly for Latino children, we know that there is already a gap in academic achievement and support services for this population. And the school may be the only way to access rehabilitation, particularly for the group of kids that are not insured. So you can get rehab through IPs. So we use a small group of that initial cohort of children. These were 387 children only from Washington State, in which we had school records. And of those, 41 were Hispanic and 346 were non-Hispanic white. And the outcomes were two. First one was receipt of any school services prior to TBI compared to after TBI. And this is just a proportion of kids. So, they're not perfect data. And then we look at a school performance by GPA among those kids that are 5 to 18 years of age. And we include all ages because you can receive services through the school as a preschooler, if you're 3 to 5, or through an IEP, or you can receive services also through a school as a IFSP, which is the Individualized Family Service Program. So here is in black baseline and in light after the injury, and you have non-Hispanic whites first and then Hispanic. So the first thing that you can see is before injury, more kids in the non-Hispanic white group were receiving some sort of services through the school, only 5% of Hispanic kids, and that's a baseline disparity. But after the TBI, either because of the needs of the TBI or because some things were diagnosed because of the TBI, then almost 28% of Hispanic children were receiving services. The other piece here is that IEPs and 504 accommodations are federally regulated, but they require a whole process to, qualify for those. So what the Hispanic kids received the most, so there were an uptick on IEPs and 504, which is great. But what they received the most were tutoring services that are done at the level of the school, and they're easier to be advocated. I think nonetheless, this is very encouraging. When you look at IEPs, and again, just so small, sorry. So I want to show that before the injury, none of the kids had any type of therapies. And here you have a 6% receiving speech therapy and 6% receiving behavioral therapy, which is fantastic. And then when we look at the GPA, so basically we look only at the Hispanic group of kids with and without services, and the group of kids that received school services had on average a 0.6 increase in their GPA, and this was statistically significant. So we know that if you're able to hook them to services in the school, they will be able to receive therapies and get better in terms of community reintegration. So this is our RCT. It's we are planning to enroll 150 Hispanic parent-child diets between 3 to 17 years of age, all hospitalized for TBI. So it's mild, complicated to severe TBI, a little bit more severe than the prior cohort. And the aim is primarily to test the efficacy of our intervention on the primary outcome, which is treatment adherence. We have secondary outcomes, which is child functional status, and we added as well to the parental piece, in addition to self-efficacy and health literacy, we added some components of mental health. So we are measuring anxiety and depression of the parents. These are our primary sites, and if you can see, I have stayed on this side of the US, primarily because this is a very homogeneous population. This is Mexican, Central American, rather than other Hispanics that look a little bit different, like our Puerto Rican or Caribbean, more in the eastern part of the United States. So we're trying to keep more in alignment with that. This is our study flow. So once we consent the patients, we randomize them. We give everyone 1 hour or 2 hours of education with the booklets, because there is so much vulnerability in this population that it's just not ethical not to do that. But then we randomize them to either the control group, which is follow-up versus by institutional policy, or intervention group, which is the 3 months intervention that I described. But we add to the RCT some videos that we send every couple of weeks, reminding it's the same information from the booklet, but reminding the parents about that. So this is the mapping intervention thing, and you can see what are the constructs that we are trying to get at, and what are the intervention activities that are related to that particular construct. These are the educational videos, and basically, as you can see, there are a series of almost 16 videos, but there are a couple of those that we send to everyone. What is a TBI? What are the symptoms? What is rehabilitation in general? Problem solving is a big one because we try to get families to problem solve, and then how to get back to school. But then the other videos are only sent if the family is referred to any of these therapies. So we customize a little bit what we send to families. Wow. Okay. So far, I don't know how I envisioned this. I apologize. So far we have recruited 64 patients. We are randomizing, stratifying by site, by age, and by severity of injury. And right now we have pretty good balance between intervention and control. Half of our families speak Spanish. And what I want to show here is a little bit about the characteristics of our sample at baseline. So it follows our primary cohort before, like they tend to be younger. It's half and half in terms of severity of injury. But what I want to show is the mechanisms of injury. So motor vehicle crash is the number one mechanism. But unfortunately, there's a significant number of kids that are still unrestrained passengers in the motor vehicle crash. And now we are having more cycling and ATV, especially in rural areas for ATVs. And these kids are also unhelmeted. So I think there's an opportunity to work on prevention strategies in this particular population. 92% of our children are US born, so they are eligible for services. However, only 31% of the caregivers are US born. So these are parents that are caring for kids that are eligible for services, but themselves, they have not experienced the healthcare system or the school system. So they really need a lot of guidance. We are able to enroll, it's a little bit old when we had recruited only 48, but the point here is we enroll kind of half of the families that we approach. One of the issues that we have is if the family leaves the hospital, it's very difficult to get contact with them. So we really need to get the family. If we get to a hospital before they leave, we have like an 80% success. But if they leave the hospital, it really drops dramatically. The other issue that we're having is that some families don't perceive value in participating in an RCT because they don't want to be part of the control. And these are families with, like we have families that the dad died in the accident, 2 kids are in the hospital, the mom. So it's just a high vulnerability. And we offer the trial, but it's just like, it's hard for some of them to participate. Retention is pretty good. We have a third party doing the follow-up, so it's blinded, but so far for those families that has finished, it's almost 95%. And this is pretty good compared to other trials on TBI, which is around 75%. And I think part of what helps is inclusive practices. So my team is all bilingual and bicultural. All the navigators are bilingual and bicultural. The study materials were informed by Hispanic parents and clinical providers. So we have a pretty good cohesive team there. We tailor to the language, but also to the culture and health literacy of our patients. We prioritize in-person recruitment, so we are pretty flexible. This is our website if you're interested. It's very simple, but it's mirrored. It's beautiful in English and in Spanish. And this is my research team. So on the left, we have all the patient navigators. And there are really people that are doing the work, and they're fantastic. And on the right, there are our PIs in other institutions, patients and families. Thank you so much.
Questions? Comments?
Question. Ocular therapy is kind of a mainstay for a lot of TBI treatment. Is there access to that within those therapy groups? Are they getting vision therapy?
Yeah, so thank you for the question. So one thing is, I have not looked specifically at that type of therapy in my research, but the intervention itself, we're just facilitators or whatever the clinicians are formulating, right? So what we do is our patient navigator gets the discharge form, but we also have the ability to look at the discharge summary and what we needed, and we help the family to get whatever the clinician sends. And it's interesting because we have the head of the rehab department in Dallas, Dr. Kim, and she's like, this patient should go to rehab. And they are not ordered rehab. So we're having this discrepancy within our own. So what we're planning for a future trial is to work with clinicians to get them to do those things. And I'm an anesthesiologist, so I don't know. But for those who are rehabilitation providers, they are very concerned that some of the things that they would think are being ordered are not being ordered. And we don't know exactly the reason, right, behind that. We just facilitate theirs. So I didn't answer your question completely, but I think that's what the trial does. Yes.
Thank you for this important work. I'm wondering, can you go back to your slide where you talk about your primary and secondary outcomes for the RCT?
Mm-hmm. Mm-hmm.
Yeah, I was wondering if I was wondering, like, for secondary outcomes, I thought that like parents' occupational status or like household income or something might also be impacted by your intervention. So I thought I just think it might have like a larger impact than what these outcomes are.
Yeah. So it may be. We're not measuring that. We measure occupation at baseline, but we don't measure that following up, right? Following up, we're just measuring this. So we may have just baseline information. Having said that, at this point, I think this is the largest national cohort of Hispanic children with TBI. Mm-hmm. So we're planning to apply for another R01 to do maybe another measurement, probably around 24 months, and see what happens. And we can incorporate other pieces. The other piece is that we do a battery of questions, and they're so long that we just had to decide, participation burden. Yeah.
I had a few comments and a question. So, well, separately, this is great work, you know. I think one of the things that is really interesting from a health equity point of view is that this is an area where there is overuse among certain populations of therapies and underuse among others. So this is the child of educated people who, falls down and hits her head playing soccer, and the parent demands, CAT scan and so on and so forth, and all of that. And I think that probably muddies some of the waters in an academic medical center where people are trying to practice evidence-based medicine. So the second comment has to do with the number of people who seem to say, yeah, we take medicine, Medicaid. No, we don't provide language services. Clear violation of the law, which most of us would advise that you shouldn't quite say that. And I was just really struck by that.
Yeah.
The third thing is, I think the Corey would be very interested in your work, and you should look at that. And that's where you can put in some of these family-centered outcomes, such as ability to return to work or impact on siblings or whatever it is that patients, family, caregivers say is really important. So my question for you is, what do you see as the policy implications of your work, right? Let's suppose do you have a sense of, are you trying to drive toward a particular policy solution?
Yeah. Okay, so two things that I can think about policy, but I'm not a policy expert, and you are, all of you. So it's a very intimidating question.
It wasn't meant to be. I was just
No,
curious.
no. No, but as I think there are several things you can affect, but one in terms of policy is health work, right? We are very good at rewarding certain types of things, right? Like training, etc. But what about people that are bilingual and bring this cultural addition to the workforce, right? Like I am part of that thing. And at Children's, for example, we take an exam and we certified that we're bilingual. And in my batch, I say I'm bilingual, but nobody pays me or incentivizes me to do that. And I think that's wrong. And I think that should change because that incentivizes people to get that type of certification, that type of thing. So that I think in terms of, and the other piece is in terms of research, right? There, we talked about this morning, like there are places in which they cannot find a bilingual research coordinator, and 20% of the US population is Hispanic. And I'm talking only about Spanish, right? What about Vietnamese populations, like other populations that are highly impacted by limited English proficiency? So I think from the perspective of workforce, we should draft some policies that really incentivize these type of people to get into workforce clinically and in research. So that's one. The other piece is a piece of navigation. So navigation is not reimbursed, right? It's actually at the level of the hospital. So the hospital works in what the hospital thinks is in their benefit. I think it's a great thing that hospitals have navigators, but they just do their little thing, right? Their thing is not transitioning the patient to a community. So I don't know how to do this, but if we are able to get navigation reimbursement for the hospital, then there's going to be an incentive for the hospital to really have navigators that work with families and patients with medical complexity, which TBI is one of those.
In California and in a few other states, community health workers are now reimbursed through Medicaid. So that makes it easier to have that sort of a model, but it's still extraordinarily hard to set up.
Yeah.
And the amount of reimbursement doesn't cover the costs.
Yeah. And California is not like half of my research people are from California. I steal people from like my
You might not want to tell us that.
Stop doing that.
But the person who manages my lab, she's from Berkeley, and she's just like, wow, right? And she's advocating for having a site here in California. But California has such a great support for families compared to others that maybe this is the place that needs this type of intervention. We work like Washington. I feel that we're a very good system. When we compare ourselves with Texas, the vulnerability of these families is just like, it's impressive. And Medicaid is such a complicated system in Texas that if you get seen in the hospital and then you have to go back to community, you have to change carriers for Medicaid. And it's just an absolute nightmare for these families. So yes, you're right. That I think that's the way to go. And we think California leads in a lot of things in terms of health services.
This is a little more comment than maybe leads to a question, but I should start. Really, thank you for the great work, and especially, thank you for your attentiveness, the importance of connecting with schools and advocacy. And I don't say TBI, but between some research and family friendship circles with developmental disabilities, it really seems clear to me that your family's ability to work the system, which is tied up with their educational attainment, income, and comfort with being comfort with asserting themselves to school authorities. That there's so much that's probably translatable. And I guess I wondered, though, maybe the question piece is to what extent, and this may not be this trial, but as a follow-on, really not just working with your navigators with families, which is great, but is there maybe a kind of train the trainer model where how can some of these parents then spread the word and help families have more confidence in their ability to advocate for their kids?
Yeah, that's a great thing. And today we talked about that, like how some parents in the oncology world, right, are being peer mentors for new families that come in. And I do think that is something that we can definitely use, or do. Yeah, it's a great idea.
Hi, thank you so much for wonderful work, super important. I'm an anthropologist, and so every time I read culture, like an arm goes. And I just wonder about how you go about it. Kind of, you say that your materials are culturally tailored. What does that mean? And how did you get there? Because we swing our cultures in a way, but it's really, really difficult to put it out there.
Yeah. So I think a couple of things, and you're perfectly. So first of all, I have to address that Latinos or Hispanics, we're a very diverse group of people, right? And that's why I tried my best to stay in specific states, right, where migration patterns kind of follow that. So that's one piece on thinking about culture. Like I would not like to necessarily think about Caribbean Hispanics or Hispanics to necessarily feel the same about it. The other piece about this, I think, I'm not an anthropologist, but I'm thinking about the culture of healthcare, right? And how do we relate as individuals with that? So I specifically was thinking about shared decision models, right? So as a physician, I practice in South America, and we don't do that, right? Yeah. Not because we don't want to, it's because, I don't know, the system doesn't do that, right? And here, as anesthesiologists are like, I'm going to do this. What do you think? What do you think about that? And inside of me, I'm like, I struggle personally with that because parents here are very vocal, right? Like, I don't want you to give this to my child or do that. Sometimes in my head, to the extent that it should not be. But my point being, that's the piece of culture that I was thinking, like how the person relates to a system. There are a few things that are less rooted in, like, they're more intuitive, let's say. So, for example, in our materials, we were very careful in trying to find pictures in which families feel reflected, right? So, for example, I work with a group of investigators. I just choose these things, but I have done some work with concussion, for example, and concussion is a very non-diverse group of investigators and researchers and things like that. So, for example, when I did this work with them, there is a website, right? At the website are these beautiful teenagers playing soccer, super lean, both of them, and very specific, right? And if you don't see yourself there, you're not going to engage with that website, right? You're not going to do that. So for example, with this particular group of investigators, there are two pediatricians and they're amazing, right? They want to work with the Latino community and they say like, oh, why don't we partner? So we went to two soccer leagues, the Puma leagues, and they're great, right? And one of their aims was to compare seeking concussion care for boys and girls, right? And there were 14 teams that were boys and one team that was girls, because we don't play soccer traditionally. It doesn't mean that we cannot play soccer here, right? Like, as immigrants, you change, right? You acculturate and you take, but so maybe that aim was not particularly well thought for that particular population, right? So that's what I refer to, like, culturally informed, appropriate. The other piece is that families told us about the specific things they wanted to know, and we incorporate that in the thing. So we did qualitative research. We put the first set of things and we brought it to patients and families and providers. And they told us what they like and what they didn't like. And they were very vocal, both the parents and the clinicians. And it was great. And then we send it to a second round to clinicians outside of our system. And for example, we incorporated people from Alaska, like other people that, and they gave us their feedback as well. So they went to 2 rounds. And then as we continue to do this research, families sometimes tell us things that they don't like or they don't want. So we do this iterative work. Yeah.
Thank you so much.
It is 1 o'clock. Thank you so much.
Thank you.